Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Micheal Darson, and in today's episode, we will discuss exploring medical practice models inside the hospital-employed practice model. Joining me today for this discussion is Dr. Anand Shridharani, Associate Professor of Urology at the University of Tennessee, Chattanooga, and staff urologist at Erlanger Health System. His main clinical focus is benign men's urologic disease, focusing on prosthetics, cancer survivorship, BPH, male reproductive medicine, and microsurgery. Dr. Shridharani, welcome to the podcast.
Hello, how are you, Mike?
I'm doing great. Well, let's go ahead and jump in. Let's talk about employed practice models. How can the hospital practice model be structured?
So there's, just like any practice, once you get down to it between academic, private, and hospital employed, there's different degrees and different hybrid systems. So I can speak for myself, and coming from my own experience, at the last probably 12, 13 years, I've been at a large public health institution located in Chattanooga, Tennessee. It was Erlanger Health System, which I was hired to be a faculty physician for. And the health system itself only had about 2 or 3 hospitals at the time, and it was one of the largest public health institutions in the entire country. It was county run, and at that institution, even though I was a hospital employee, we were able to have an affiliation with the University of Tennessee and start a residency program here for urology residents. And so I've been an employed physician for over 10 years in a health system. You can be employed like some of my other colleagues are at singular hospital, and that could be as an individual within a group that's employed, or have an affiliation with a PSA or primary servicing a specific hospital and have a hybrid contract with the hospital itself. And there can be managed care organizations that also have a hospital system affiliated with it, that you see primary individuals who have one specific insurance, but you are in an employed model. So there's multiple different ways that the hospital structure can occur, either by itself within a system or affiliated with private practices or academic practices, at least what I've seen in my own experience with other colleagues. So it's a very broad kind of model, and I guess we're going to get into all the different specifics about it as we go along in our discussion.
Sure. Hospital versus health system. Tell us about that one.
So health systems usually incorporate with multiple different care sites and facilities. Systems may have multiple hospitals as well as primary care clinics that emergency departments, different places of care. Hospitals by themselves may just be a hospital with the routine like operating room, inpatient floor, and emergency department. So it's the difference between size. Hospitals can be very large and very small. Hospital systems and health systems can be very large and very small. So it just really depends. And those sizes of the settings can also be determined by the demographics in that area. So you can be taking care of a large amount of patient care lives or a small amount. And obviously they vary between urban settings and rural settings.
So how about talking about individual versus group models?
So sometimes hospitals will employ a faculty urologist or any sort of physician to take care of that specific skill set for the hospital, either alone or within the group. Sometimes there are groups that are employed by the hospital that sometimes they stay together and they make decisions together, or they could be individual urologists that don't necessarily have the same practice goals, and they may have different needs, and the hospital may engage those individuals separately. It really just depends on how the infrastructure of that service line is from the hospital standpoint. Really, the hospital itself will determine what that cohort should look like, whether people will be treated as individuals or as a group. And then there's pros and cons to each of those things when it comes to negotiation and with leverage in terms of decision-making capacity.
Sure. You also mentioned affiliation with managed care organizations. That seems to be increasingly popular. Can you tell us a little bit more about that?
It's just like a Kaiser Permanente. It's one of the bigger managed care organizations that will conglomerate amongst hospitals. And really, it's all about leverage, about cost savings. And in those systems, they seem to be a little bit more rigid in terms of their compensation structure and how many patients you see, how many patient care lives that you take care of. However, it's very predictable, and they tend to have good pension structures and benefits, and the predictability of those systems as far as the clinical care you may offer seems to be a real highlight for them. And when you have a single insurer and a single system, there is definitely so much room for cost savings. So it ends up being a very efficient way to deliver care. And then obviously there's pros and cons. Like you have a physician that you like and that your employer says you have to go to this managed care organization, you may lose the physician that you like if they're not part of that managed care facility. So there are pros and cons to those things. There may not, everything under the sun may not be available by that managed care organization. However, it does seem to be efficient as long as you live close and have access. And usually those organizations, a big part about how they get more covered lives is through having access to their facilities in multiple different locations.
Yeah, it's interesting. I think there are some communities where the physicians kind of band together and form a managed care organization and use different kind of quality metrics and all that kind of stuff to kind of approach payers and systems with. Have you seen that in Chattanooga, or have you seen that anywhere nationally?
I've seen it. Just all depends on the leverage and ability of that group of physicians to have a like mindset and believe that they can do it. When you go out in a group setting and you're not going to get the same amount of reimbursement as a hospital system that has more lives. And so the only way you can negotiate is by getting more practitioners together. And so by doing so, that has been, I know it's growing in some areas. It just depends upon the demographics where they're successful. Do they have a cohesive mission? Do they all agree on how their board structure and administration structure works? So in Chattanooga in itself, not as urologists have we formed one, but I've seen other people at those managed care organizations. Yeah. But I'm more familiar with with the larger ones than the smaller ones that are formed. Right. Multi-specialty groups are here in town. However, that they haven't completely transformed into MCO.
Got it. So you mentioned that some of these models are dependent on demographics and regions. Is one of these models more popular right now than the other, or
within hospital organizations, or between like private, academic, and hospital?
Well, I guess I'm asking the bigger question, like of the models that we talked about, is there one that's a lot more popular or a lot more of them nationally or regionally?
So, we can look at like AUA census data and see that there is a general movement towards hospital employment. How that is graded out, whether it is one sort of model within that hospital employment or another, I don't quite see that huge of a trend. You see what the census would show, and then you hear about how the pendulum is swinging the other way. I mean, there's one of the main disadvantages of hospital system practice is administrative bloat. And I think we're getting kind of ideas of how to help that. I think we're going in a direction of sometimes that would be counterproductive to clinical care. I think people are aware of that, and then people try to run lean and make either efficiencies within their practice model or choose to create another model or join another model. But I do know that generally the national trend has been towards hospital employment versus other models. But I think everybody is trying to work towards something that can provide clinical care that's efficient, that would make it sustainable as well. Sometimes models that try to be too efficient or try to be too cost cutting don't allow you to have the practice that you want. They're not sustainable, for quality of life for the urologist and for patients necessarily. If you try to get water out of a stone in every single situation and not invest in some necessary clinical needs for the practitioner or patient, you're going to end up with a non-sustaining model.
Well, that's a good transition into the next topic, which is compensation in a hospital model. How are hospital employees compensated?
Very many different ways. It depends on also which region of the country you're in, whether that hospital system has a certain way of doing things. And some hospital systems that are very large, HCA or Common Spirit, those things like that, atriums, they may have one model that they apply everywhere. And sometimes they can be variable depending on what kind of physician you are and what the market bears for a specific type of physician, or they can be very fixed. One of the classic ways to compensate a physician in the hospital employed model is by a RVU basis, whether that's based on a percentage based like usually at the 50th percentile. They may have an RVU quota that they assign at the 50th percentile of either collections or overall salary, and that they may have production bonus if you hit other metrics such as the 75th and the 90th percentile. Sometimes hospitals will just say, here's your flat pay, and you don't have to hit an RVU quota, and this is just what your salary is going to be. Sometimes there's a growing movement of people who would rather just say, here's what my salary is. It's predictable. It's not the highest. It's not the lowest. And they may be getting either more if they're in an area that's underserved, or they may be getting less if the area is competitive, like in a bigger city like New York or Boston, San Francisco. If there is high competition there, you may expect to get paid less than someone who is in rural Kentucky or rural Tennessee. And so those compensation packages vary. If you do have a group and there are multiple urologists already there, you are more likely to get what they have, unless they do separate it by either experience or participation in other hospital activities that improve their ability to obtain revenue, like quality, research, other administration and operations, things like that. Sometimes there are other opportunities to get higher compensation, but then you're just generally shifting your role from predominantly clinical to other opportunities. But generally what I see is you come in with a salary and that's set at some RVU basis at the 50th percentile. Maybe if you come in fresh out of training, you will be a little bit less than the 50th percentile. Usually they're pretty good, depending on the structure, about looking at the contract every 3 to 5 years maybe, and depends whether they have evergreen policies or not. So it's every contract seems to be different from every hospital that I see. And so it's just a matter of what are they offering and how do they compare. Sometimes it's apples to apples, sometimes it's apples to oranges, and that's when it becomes difficult.
Yeah, I've read a few contracts over the years, and I'm always surprised at the variability. I mean, some of the contracts I've seen are draconian, and others have evolved to reflect the current times, and it's pretty amazing, the variability.
It's speaking of draconian, and sometimes if there aren't urologists already there or there aren't surgical subspecialists, they may not even know that they are they are offering a job that's not at market. I've seen this with multi-specialty groups before, and even some hospitals that require somebody. If they haven't done the research, sometimes they require a third party, not just looking at MGMA. Sometimes they need a third party to officially approve a salary package, and it may be way off, especially if their projections of what their demographics are, of their patient lives. I mean, we all know that there's a general workforce shortage for urologists. However, the compensation metrics don't always reflect that, and how, we have a aging workforce, we're having people retire, there's more clinical burden, EHR, there's higher risk for burnout. I don't think that's always taken into account when creating a package. And honestly, that's why some urologists coming out who are exceptionally new, they like the idea of it being predictable. I come to work, here's the amount of money I make. I don't have to see more than I want to or less than I want to. The more predictable models and salary packages sometimes are more appealing. Unfortunately, you don't know when you work for a hospital if your practice at one point can necessarily change. You do lose that ability to have control of how many patients you see, how much support you have, in some certain systems. If a hospital system gets acquired, but that you are employed in that service area, they have an access to care issue, and they want urology there, it may be out of your hands. You may have to go there, and I've heard of that so many times, and that has led to physicians leaving that area, and then it creates a worse access to care issue. And so we'll probably talk about that more. It's all about communication, and it's all about understanding your contract when you do sign. Is that something that you are exposed to? And some people may find that, no, that's not a problem for me. I do want to do as much as I can and offer as much service as I can. But, I think, and this is what I tell my residents all the time, you go through training and you're like, you see everything, do everything, you get really excited, and that's what you want to do when you come out. But you're only one person, and, you can get burnt out pretty quickly if you don't have realistic expectations of, one, what you want to do, and two, like being able to control your free time, especially if you have a family, other things that you like to do. So that work can easily take over your life if you let it.
Yeah, for sure. One of the things that we talked about was a compensation model based on RVUs. What are some of the potential problems with a model based on RVU production?
So RVU production, they usually have a percentile of RVU production for a certain area. Usually that's like they have it by region, like Midwest, Southeast, Central, that they generalize how many RVUs, what the distribution would be for urologists practicing in that area. Sometimes they have it by urban setting, rural setting. Sometimes they have it by academic setting versus non-academic setting. Once they have that distribution, they are able usually to set a number. And I've seen the 50th percentile often quoted as, here's a number that you need to reach your base salary. And there's a certain amount of value to that RVU. Now, if you have a flat salary, that most likely may be your flat salary or some percentile. It's not necessarily arbitrary. Hopefully the hospital has done some research into what can be achieved. So being a good fiscal steward, they're paying you what you're able to produce. However, with workforce shortage, I know plenty of people who work and they do obtain an RVU bonus. So if you have a bonus structure, that's also a sign that if you hit a certain percentile, either 75th or 90th, that you may have bonus on top of that, depending on how many RVUs you make over the 50th or 75th or 90th. And that's assigned a value, and that value is, one, also determined by your region, or two, it may be not determined by your region, and the hospital themselves may set that number. And that's sort of something I'm more familiar with, that they could get a third party and say, here, what the market bears, this is what we're going to give you, and is this reasonable enough for you? And so if you are capped and you're like, this is your flat salary, and you're being made to do extra work. It can make you feel bad that you're doing a certain amount of production and you're not making any more money over a certain amount of over the number that you're actually paid to. That can become extremely problematic, and you get through up to September or October in your year, and you've made your 50th percentile and everything. In the next 2 months, you're not gaining any more revenue for what you work. If you had that agreement from the get-go and you're fine with that, great. But sometimes bonus models do make sense. It does pay you for how you work. It's not based on what your collections are. It's whatever you operate or see for patients, you get that actual amount back. And that's what's nice. You don't really have to check people so much what their insurance is. Is it great insurance? Is not great insurance? And so that's one nice thing about it. The downside would be if your RVU value is not set to what the market bears and it's low, you may not be getting paid what you are actually making for the hospital. Or if you have fluctuations in your practice and you are under what your 50th percentile is, there are some institutions that have something called clawbacks, where if you don't make that number, they're essentially loaning you the money to pay you. But if you were under one quarter and the next quarter you have a bonus, you're up more. But if they loaned you that money to give you the 50th percentile, they can dock your bonus a little bit, so they can take your money back. And that's a contractual vehicle, so they can make sure that they're good on their side. I mean, I've had so many people who have complained about that particular contractual clause, but it just depends on how predictable is the system you are going to work for. Are these things discussed ahead of time? But those things can be quite problematic if you don't have that discussion. The other thing is the hospital open to having these contractual discussions with you? Some people are very hard pressed. Some organizations are very hard pressed to keep it that way. They often say, well, the other person has it this way, or everybody else in your group has it this way, and they haven't complained about it. So if you are in a situation where there are other urologists practicing with you, you are all employed, then you can work together as a group to say, here are what our needs are, and negotiate with the hospital, because you can control that service. That's sort of the model I'm familiar with. That's what we have here. We work well as a group, even though we're employed by the hospital system. We do make decisions together, and it's been great to work together with like-minded individuals to stay together, and also use some leverage we have for our urology service practice to get what we want. And that's not necessarily, it doesn't have to be just compensation. It can be other things such as resources, staff support, instrumentation, anything to get the job done. And then so it doesn't have to be remuneration to be the only thing and last thing. Compensation is only one part of the whole entire picture of practice, obviously.
Yeah, I know I know personally several people in different parts of the country that have went into a model where it's primarily RVU, structured on RVUs, but then they get to the facility and they don't have enough nursing staff, they don't have enough OR time, and all those things that kind of curtail production, and that's led to some physician dissatisfaction for sure.
And COVID is a great example when that affected a lot of people. That some hospitals said, hey, you can't work, you have to take time off, and your compensation is going to change, or these people have to be out and you don't have the support you need to see the patients you want. And I think in that setting, we were all in it together. Some did it well, some didn't do it well. However, if you don't have a voice for either yourself as a group, it's very difficult for you to get things done. And if you have a good practice manager or hospital administrator, life makes it so much easier. Our business director, does performance for us, advocates for us when we're all in the operating room, comes to our own meetings, leads our agendas, and allows us to communicate when we can't, because it ends up being at the end of the day, beginning of the day, we're there to provide clinical care. And so if we have someone on the admin side that believes in what we do and advocates for us to the hospital, that's great. We've also been in settings where our hospital administrator didn't advocate for us and just, whatever the C-suite said, you guys are going to do this. That didn't work out so well. Right. So it goes both ways in these systems, and just like in any other model, an academic model, private, it just depends on if everybody can get on the same page. Everybody always doesn't get everything they want, just like with any negotiation. But if you can find middle ground, that you're there to provide good care, efficient, try to minimize burnout and administrative workload, I think you can find something that's sustainable.
Agree. So what would be the potential advantages of working for a hospital system?
Like I spoke to before, depending on how your contract is, you can have financial stability if you are at a certain number at production that's easily attainable, and if the hospital uses normally published metrics to assign staff to you in terms of support. Do you get a nurse or an LPN? Do you have a dedicated front desk staff or someone who's trained to manage your urology service? Anybody with urology service specialization within your own clinic helps so much with managing care and of your patients. And do you have someone to answer calls for you, for clinical questions, depending on your production and your management of care lives. Do you get support with a PA or mid-level provider? That's I found to be a lot easier to do. I mean, you're usually in the hospital system, you technically are not paying that out of your own pocket, where in private practice models that may come out of your bottom line. And in our situation, our mid-levels, that whatever work they're doing, we're not getting paid for their RVU production. So the hospital is, and so actually it's financially viable for them, and they're more open to do that. And I love the ability for us as urologists to work with mid-levels. They make my life and the life of my patients so much better because of our access issue, and they allow us to do so many more things. So I've found it much easier in our system to get APP and mid-level support. A lot of times the benefit structures are very good, especially if you're a part of a health system. Their access to care is higher, and so they do have more leverage to get a better benefit system. For Blue Cross Blue Shield of Tennessee, we have our own Erlanger Health System plan. And so that allows us to see everything within our large system. And it's not as high of a cost as if we were in a private practice model, or private practice models sometimes do a lower cost option. You may not have the same access. And so that's important. Malpractice is usually covered. Tail coverage is usually there when we go into bigger hospital systems. And that you don't have overhead to worry about. A lot of the things about private practice models is that depending on how lean you run, your overhead may be a huge consideration. Mm-hmm. And if you are paying for your support and your clinical staff, just the idea of going on vacation. Obviously, there's some opportunity cost there, but I hear about people all the time, not just urologists, but other my relatives who run their own practice, small practices, 3-4 physicians, surgeons. They're like, well, I can't go here or I can't go there. I gotta stay and work. And that's not a great way to live your life. And so you don't really have to worry about that quote unquote cost. I mean, some people like to look at that, but again, you gotta take some vacation at some point in time. And then at least we are in Tennessee. We have our malpractice is we have good tort reform, and our malpractice is covered for most physicians during the state, and that's covered. So that's also nice. If you, and like I said before, the biggest thing about predictability of what your practice is going to be, the more predictable of patients you're going to see is, and how much help you're going to have. I honestly believe that helps with the quality of life in your practice as well. If you there's not going to be a lot of changes, you can do other things in your practice to kind of want to grow the practice, market a little bit better, and not just focus on the day-to-day clinical care. How do I get my patients through this clinic, or how do I add this patient on in the OR? you have a lot more help in those other situations. But when it comes to, marketing support, what else can the system do for you? That's sort of a mixed bag. How much other investment will you get? Sometimes hospitals will market very well, sometimes they won't. Usually when you come in new to a practice, you hope that they would market you and provide you with some investment to allow you to be successful, and just the same as you will be successful for them. And so if that discussion is had, I think that's also a beneficial thing if they're having that discussion. So advantages strictly to the hospital system in terms of pay, it seems to be a little bit more predictable if you have the right compensation model and you don't have to worry too much about overhead. The other part of the support system with regards to marketing and accounts receivable and all that stuff, that's sort of a mixed bag. It just depends how well your health system runs. Mm-hmm. Sometimes the better the health system runs, the less you may get paid too. So if they're having that higher investment for those other support parts, then that you may have less pay, and that may be a adequate trade-off for you. And I've also found that specifically with our hospital, anything we want in terms of instrumentation, lasers, robots, HIFU, and we may be in a special system, but they've been very, very supportive for operative instrumentation. If I operating microscope for me, and obviously on our end, we have to put together a pro forma that would make it worth their while and that we recoup our the amount of investment, or that it provides an innovative technology that can affect our population in a positive way. We make those arguments, but they've been pretty good about providing us with at least the cutting edge innovative side of urology, which is awesome. I mean, that makes it super interesting for us as a group. Again, all systems may or may not do that. However, I find that ability to get that would be a lot higher in a hospital system or maybe an academic system, more so than a private practice model if you have to pay out of pocket for some of those newer innovative technologies.
Right. It sounds like, there are definitely some very good potential advantages, and one of the keys is being a good communicator and making sure you have a good administrator, and just positive interaction with the healthcare system. So how about disadvantages?
So there's plenty of disadvantages. Again, what you're looking for in a structure. If you do want to be in control of your schedule, of who you hire, how your customer experience is, and you want to be able to create that from scratch, I think you cannot necessarily do that in the hospital system. I wouldn't say no one could do it. I just think that that's a little bit harder to do if you have, especially employment policies and hiring policies that are dictated by the hospital. Specifically for our situation, you're going to get nurses, MAs, LPNs, all your support staff who are at a certain level of pay. And that's what the market bears. However, taking what we would do in our clinic compared to a primary care practice where we may see maybe 2 to 3 times more, we're doing way more procedures, what our revenue or production would be in our practice and what our demand for our nurses in terms of how quickly they move and things like that may be completely different than somewhere else, but yet they get paid the same amount. And so whether, you can argue whether that's right or wrong. However, we do tend to have a higher rate of attrition because they could just go to another practice, not work as much, and get the same amount of money. So it takes special individuals, and if your hospital is not at market or somewhere off that, there's no, and it's like a 5 minutes to the next health system, why wouldn't you go work there? So right. In terms of, and we're fine now, but we used to be a county hospital that changed into a 501c3 recently, and so we're getting a little better, finally being able to pay our staff up to market. But before, it was on the docs to try to create a culture that what we offer in terms of collegiality and treatment of our staff would be better. That we could create it to be more predictable, better culture. So maybe that $1 to $2 or $3 difference or what have you, we could offset that by just how it was in our practice. So, and staff turnover is something we all deal with. And sorry, what were you going to say?
Oh, no, I was going to say you hit on a hugely important point, in my opinion, is the physicians and their ability to create a good culture and a good work environment it goes a long way.
Yes. And that's always a work in progress. I mean, the more people you have, sometimes we get to a good culture, we have the correct amount of people, and it's really easy to do, and then you expand, and then it's hard, and so I'm a big mission person, and having principles of practice, guiding principles for our practice, for the residency program, and so going back to those things is something I always try to impress upon everybody there. And people understand it and some people don't. And, part of it is how quickly can you get our staff involved in what you do, get them excited about it, and have them have a set role. Sometimes it's difficult when you don't offer the same pay as other health systems or other models. Are you able to compete if they never even make it in the front door? So, and I think that's something that not just hospital employed models struggle with. I think that's something that may be ubiquitous across all models. But I guess the point would be, create a good culture as much as you can and try to limit how much turnover you use. You have someone with you for 2-3 years, you get someone new, it takes them 6 months to a year, just to get on board. And that investment, even if it's just asking for 50 cent or like dollar raise, and I guess that's a kind of old way of thinking, but like maybe $3, $5 or something like that, is that really a lot to have to go and train somebody else and lose the efficiency that you had with that one person? And that discussion, I have found that in hospital systems is a little more difficult. It's a lot quicker to do that if you isolate a key person in your clinic who does their job, does it efficiently in a private practice model. Yeah, why not pay them more? And do what you can do to retain them. In the hospital system, it's like you what you do for one person, you have to do for everybody. Again, it's really plain to see, and it's not like it's hidden. So you sort of expect that. However, as I've moved along, depending on who the administrators are, there's ways and tricks that we can do things and assign more tasks and put them in different classes to allow for better pay structure for key personnel. And so, again, it goes back to that communication and how open they are to do it. I think at least with my own experience and some of the experience of other people in the area, with a period of intense administrative bloat and inefficiency kind of went the other way, we're coming back towards a position of where, okay, how can we be efficient on the practitioner end and on the administrative end? And I think there can be some medium that's reached. There's always going to be one more than the other. However, the process of doing so is really important. So.
There's a couple things about turnover that I've noticed over my career. Number one, it's inevitable. And number two, it's expensive.
It is. It's expensive with money. It's expensive with time.
Yeah.
So and it's just one of the realities of practice. And so, turnover is one big thing. Again, I don't think it's somewhat ubiquitous. It is somewhat ubiquitous with all practice models, but how we deal with that, who you have to talk to, it may be easy, maybe not be easy in a hospital system. The other thing we sort of touched upon was productivity pressure. Hope people don't get into a situation where they're like forced to produce or they feel pressure to produce to this certain level. If it was made clear and someone's underperforming, the hospital should be there to help and find out ways that they can support, because there are situations when you're quote unquote underperforming or not reaching your quota because of system issues that you don't have control over. And you mentioned that earlier. And so that's a very difficult situation. And if there's no discussion in that situation, if you have the ability, I think move, get out of that situation, because if you're sort of destined to fail. And I know from I guess, earlier generations in practice. I don't know how many newer generation urologists come out, and I think the newer generation coming out, at least I know from my residents, a lot more time goes into how they will structure their contracts. They're more wary of things. I don't know if it's because we're telling them to do that, and they're in a hospital system where they see that our business discussions all the time. However, just don't agree to the first contract you get, and ask a lot of questions, and doing due diligence to find the right fit is really important. Yeah. I don't know why I think this, but I think that the newer faculty or graduates coming out do a little bit better of a job, and I think it's because a lot of us have gone through multiple situations, and I think mentorship is improving overall, especially as we have workforce shortage. We have to lean on each other and learn from each other. Mm-hmm. And so with that knowledge, I hope people don't get in bad situations. So before you sign on the dotted line, you really got to ask around and do that. And if red flags are everywhere, or even they're one place, you may want to look somewhere else.
Steer clear. So I always like to ask a question from like a resident standpoint, or even a more seasoned urologist who's thinking about switching jobs or situations. So what are your recommendations if you're considering hospital employment?
So it really depends on where you're coming from. What you have a central worldview of practice from what you experience. So you know what you like, what you don't like. If you know a hospital system, you're moving in somewhere, an area, and you have someone at that system, it's very easy to get information. And so it tends to be a little bit more predictable. I don't think there's a lot. I think there can be less fluctuations in the clinical practice in a hospital employed model than there can be in other ones. Depending on what the practice is like. With a private practice model, if there's a need and it's turnkey and you go in, you might be seeing a whole bunch of people immediately. You may not have the ability to affect the change of how you structure that because of how much volume you have. With a hospital, if there is a need, again, you may see multiple patients immediately and have less time to figure things out. But if there is a pre-planning there by the hospital to add someone because they'll have future need, that's a great situation to be in, because you can work yourself into it. If you are considering hospital practice, it's really good to know how a network can be performed. A network can be identified. Networking is important in sort of anything we do. If you figure out what the administration hierarchy is and there are people you like, that's a great situation to be in. Again, it goes back to communication. If you notice that hospital allows you to have instrumentation and tools that are not available to you, I think a hospital situation or an academic situation may offer that more than somewhere where you have to think about the bottom line all the time. And also, as far as private practice is concerned, and this is not all private practice, what I've heard is that, my pay fluctuates, and I do overhead fluctuates, and those fluctuations can sometimes lead to stress. Some people aren't stressed out about it at all. Some people are. And if you want something that's a little bit more predictable, and you've done your due diligence on the hospital, and for the other practitioners there, if there are some, they are reproducible, that's a great situation. But that all becomes with the information you have beforehand.
Right. And
it also, you'd want to know contractually whether you're going to be at one site, multiple sites, things like that. I've personally lucked out specifically with my operating room. My operating room is the best. I love it. They're super efficient. Turnover times are like half an hour. Get 2 rooms, and I'm very happy. We have a very efficient OR in our hospital system. Clinic, have a great staff, and so it didn't come without much turnover to get there. I've been here for over 10 years, and it hits a nice level. But there are great things about it, and whenever I want to take vacation, I really don't have to worry about it. So it's and everything moves on. I have a support system that kind of runs. And so that's really nice. And you can get that in a private practice model too. It just is to be clear about what exactly you're not getting at your current practice model, and figure out whether you are going to get that from the hospital employed model. Right. And that's being very clear about what you want and will you get it there, and then asking everybody around, is that something you can achieve? Grass is not always greener. Right. I think all of us at some point in time have been like, this is tough for me. This is difficult. Is it better over there? It sounds like it's better over there, but you get over there just because someone likes it or they're recruiting, you may find it that's something else, So having those key things, what those important facets are that you require for your own happiness and sustainability in practice, always write that list down and then see if that practice model can achieve it for you. And the other thing is, if you are in a practice that does not necessarily need a lot of specialty support, it'd be very easy for a hospital to provide that for you. And that goes to locums, if someone needs coverage and if you're doing general urology and it's not a situation where you're used to having every newfangled thing and you are someone that can make everything work. Hospitals, especially rural hospitals, may be great. You may get a better quality of life if that's an area you like to, it's closer to your home, or it's nice just to be peaceful, or you like the outdoors. You can pick a specific place for that reason. And so there are a lot more hospitals, I imagine, you can join than there are the private practice models. And I'm just saying that maybe I'm wrong with that situation, but I think there are more hospital jobs than there are other model jobs available.
Yeah, it's definitely an ever-changing landscape out there with private practices and hospitals and everything. So yeah, a lot of great points, a lot of good advice. I will say the one thing that I just picked up from you is I think your ideal OR environment is a direct product of how much work you put into it. Would be my prediction. I don't think
so. We do a lot, and obviously I got into urology and do what I do because I love to operate, and they've been supportive of us operating. And we were a county hospital, and it was run like a county hospital, but the ORs always ran not like a county hospital, and so. And the staff that I work with, OR staff, are amazing. My clinical staff's amazing. So the people I work with are great. My biggest beefs are always, the turnover, the pay rates for them. How are they supported? Are they supported the same way I am? Do they feel like they're happy where they're at? And so, and the environment always changes. Depending on what the fiscal structure of the hospital is. Are there other areas that are running just as efficiently as us? If they're not, are they affecting our ability to get investment and our staff to get investment? Yeah, that happens all the time. So you're just evening it out instead of a group where you can make decisions on the fly that, you have a few people, you look at the number, if performance makes sense, let's go get this, or let's do this for investment. It may take me months, so, and yeah, I have to deal with that, but as long as I get in the operating room, I can find my happy spot, and it's worth it on that end. So it's not always grass is greener. There's another thing about ancillaries. You always hear about the ability to have ownership and equity. And one of the other big things, like I build this service, this mental health service for our specific institution. But I don't necessarily have any equity in it. It's not like something I have control over. Not equity in terms of compensation necessarily, but equity in what I've built and building on top of it. There's no real power except the trust that people have in me to do what I'm doing. But it's not transferable with me. And so if you do have equity in a private practice, and that those things may be transferable, you can split it up, you can put it together. I don't have that necessary ability to. And those are things that, I've thought about more mid-career than I did beginning of my career.
Sure.
And so, when you come out, you're looking for predictability, you're looking for a place to build. If you have that entrepreneurial spirit, not to say that you can't do that in a hospital, but you can probably do that more in a private practice, especially if you're good with numbers, you're good with teams, you're good with efficiencies. You may be very successful doing that. Not necessarily as a solo practitioner, but even when the group, I think all groups, whether they're hospital employed, academic, or private, like someone who has some other ability to do numbers and do efficiencies. Not to say that I have that, but you always want someone, to have a value add within the group to do something beyond just clinical care.
Right.
I think that's always a boon if you have someone like that. So, there's all these little things to think about. And that's the thing. This is the dynamic process. When something that's important to you at one time may change at another time. Being open to that and having honest conversations with, your family, your partners, being able to have that discussion is really important to find out what you want. And so I think I'm being more generalized about this discussion, but I just find that what you want as an individual practitioner is really important. And hospice employment has been great for me. Not to say that that's the only thing you should go to. So hopefully it kept it even, and I love it here. And so it's been great. But I have reasons for that. And so that's all I can speak to.
Well, this has been very informative, a lot of good information. Thank you, Dr. Shridharani, for sharing your time and expertise with us today.
Appreciate you, Mike. Thanks for having me on.
And thank you to our audience for joining us on the AUA Leadership and Business Podcast. Until next time, continue to learn, lead, and excel.
Make AUA Leadership in Business your go-to podcast. Subscribe today by searching Leadership in Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.